Hello, colleagues. I will be present the live case. The patient is male, 57 years old, presents with claudication pain in the right lower limb and 150 to 200 meter distance. Medical history for peripheral artery disease. After successful recanalization of chronic occlusion of the left superior femoral artery after artery 1 month ago. Comorbidities, coronary artery disease, one vessel coronary artery disease, 75% stenosis of LAD in mid-segment, diabetes type 2, arterial hypertension, and dyslipidemia. Risk factors, smoker, male, and age. From ultrasound Doppler, the result is subtotal stenosis of right superior femoral artery and subsequent occlusion in the mid to distal segment. Chronic occlusion of the right anterior tibial artery, collateral blood flow in the right posterior tibial artery. The first picture is SFA occlusion. The second one is collateral blood in a tibial posterior artery. The ABI ankle brachial index in right is 0.59. The therapeutic method in this patient is endovascular treatment of combination coronary artery disease and peripheral artery disease. Our strategy is right radial approach for the implantation of the coronary stent of LAD and right posterior tibial approach for the retrograde occlusion of the right superior femoral artery. The two approaches are finally closed with compression. For now, proceeding to the live case.
Okay, Gladius 018.
Do you hear us?
Yes.
Yeah, excellent. Thank you, Dr. Yaneska, for the presentation. In fact, both with my team, Professor Stankov, Lydia, Dani, Iskra, we are going to try to speak and to show our experience regarding double approach, remote, regarding the 018 microcatheter. We are going Trailblazer. Okay, we are going to share with you our experience, and during the years, Professor Stankov will explain you what part of the procedures we are performing with combination of arm and tibial approach.
Yes, I told on my presentation, colleagues, he's listened. No, this year, the percent of the tibial approach for the peripheral artery disease of the superficial and popliteal artery, it's 33%, and huge percent compared with the previous year. I don't know, maybe you like it more and more, this approach, or the patient, it's...
So we avoid femoral puncturing. It's in case you have some comment, we are listening to you. You probably see the long SFA occlusion, very typical. We are in Bulgaria. We are on the Balkans. So in most of the cases, we receive patients with not stenosis, but with total occlusion of the SFA. And of course, I will listen to your opinion, but you probably will share our opinion that in many cases in which there is a huge collateral from the proximal cup, the penetration is not very easy, and in many cases the wire has the trend to go subintimally, so to make a dissection. And of course, it's better to stay inside the lumen. And because of that, we prefer tibial approach for the penetration because the probability to stay in the lumen is quite higher. What do you think?
Yes, my first question was you're trying to fix the all problems of the patient, coronary and in one procedure. What is the reason
in the majority of the cases, yeah. In fact, we are choosing the most clinically relevant pathology first, and we go as a second step for the other pathology. So, because in this situation we don't have critical limb ischemia or rest pain, it's in fact an elective procedure that was planned quite carefully.
Okay, and retro approach is my favorite. That's why I
Yes.
agree that from retrograde is better to recanalize. There's a lot of reasons for that. You save the lumen, because if you go and insist on antegrade only, you can, in most of the cases with subintimal approach, to lose some normal lumen vessel lumen. Sorry. That's why
Okay,
retro
great.
is
Absolutely.
better.
Yeah. In fact, what we are doing in most of the cases, we put a radial or brachial long catheter or long sheet in order to visualize the tibial, the distal tibial target. And in this situation, we have really excellent distal tibial target. And yeah, it's this is before the puncture. You see that the posterior tibial is really excellent vessel. Excellent. But in case the distal target it's not so well visible, we are using the trick to puncture the calcium. So in most of the cases, it's a calcific disease. And you see the penetration. The penetration, we are generally putting the 5 French sheet, a radial sheet. And through the 5 French radial sheet, you know that nowadays we have plenty of devices that are compatible with 5 French sheet. What would be your choice for the wire? For the wire, how to penetrate?
My favorite wire is mostly advantage wire, 018.
Excellent. Okay. Absolutely,
Because
it's a very
multi-purpose
good
wire,
option.
a lot of situations. Sometimes, and I never said that, but sometimes I use the other tip of the back tip of the for the strong penetration, and very useful wire for me. And advantage is the good name for this wire. I don't know.
Absolutely, great choice. Great choice.
The problem
Absolutely
is
great.
not a cheap wire, so we are usually starting with something cheaper, maybe V18 or
We are going.
command, and occasionally switch to advantage.
Okay, we have chosen one of the varieties that you are commenting. In fact, this is the Gladius. We like very much advantage. It's a little not so predictable, the advantage, and because of that we are using, in case we want to stay definitely inside the lumen. Go ahead, slightly, slowly. We are using advantage. We are using Gladius or command. Roadmap. We did a roadmap. It's probably we are still subintimally, unfortunately.
Yes, in this part with calcium.
Yeah, there is
Remove for the second roadmap.
like I had commented already.
Yes.
The huge collateral, the place of the distal and proximal cup is one of the, unfortunately, predictors of going subintimally.
And that for now we try to the going from the
Try again.
medial part of the artery.
Yeah. We are retracted slightly back. Go ahead. No, it's definitely subintimal. Oh, this is command.
Let the try to the crossing from the other side of the calcium.
So,
Remove the roadmap
okay, we are retracting back.
and try to the
Try again, okay.
crossing from here.
There is a calcium roadmap there. It's probably intermediate cup.
Yes, this is different.
It's probably, yeah, this is a different place.
And now proximal cup
This
of
is the proximal cap.
No.
Okay, I'm advancing the microcatheter just to be just beyond the proximal cap. Try.
What kind of catheter you use? Support catheter?
This is a 018 Trailblazer supportive catheter. Trailblazer from Medtronic, yes.
No, return.
It's we advanced slightly, and we can choose even a coronary Gaia the third, for example, to penetrate the cap.
This is again subintimal.
Okay, let's try Gaia the third. I will try to puncture the calcium on the distal cap with a coronary style CTO wire.
Stiff coronary wire.
It's a very stiff and very aggressive coronary wire. Okay, let's remove that. Okay. You see the distal marker of the Trailblazer is just below the proximal cap of the SFA occlusion. And we'll try to puncture the, okay, there is a very small curve, you know, the cardiologists know how is the Gaia the third looks like. It's with a very small curve on the tip, just in order to have the possibility to penetrate.
From here.
Okay, so we are straightening the microcatheter like that, to be straight, and to try to penetrate. Remove the roadmap for a while. Put it again. Advance slightly the microcatheter. Stop.
Okay.
Okay. Дай ми roadmap. Махни го. Дай го. Махни го. Yeah, I'm inside.
Yes.
Okay, good. We succeeded.
Yes.
Advance the microcatheter.
Remove the roadmap. Okay.
Definitely, there is a very free movement of everything, so obviously we are not anymore subintimally. And we are going to replace now, like in the coronary procedures, we are going to replace the penetration wire with supportive one.
Advantage.
Advantage, yeah.
Yeah.
We have already discussed that we prefer very much Advantage. The name of Advantage, by the way, By the way, I don't know, is it possible by the camera to take a look at the microcatheter, but you can probably observe that there is a backflow. So you see there is a slow backflow from the microcatheter. That is one more, in case we can zoom. Yeah, absolutely great. Okay, and we are going to see several drops of blood coming. So it's absolutely spontaneous. Yeah, it's already seen. Excellent. Thank you so much. So it's obviously we are in the true lumen of the SFA proximally. And after putting the supportive advantage, that is really excellent supportive wire, we are going to proceed with non-compliant balloon, and in case everything is going smoothly by vascular point of view, we are going to avoid stenting, and we are going to finish with DCB, with drug coating balloon, with very good results, not only in the trials, but also in our experience. What is your panel suggestion? Do you some of you, because I know there are different practices, some of the colleagues are practicing direct stenting, but we are not so much keen. We are not in favor of stenting, because in Bulgaria we don't have no one of the available drug-eluting stents, and because of that we avoid direct stenting.
My tactic is to leave nothing behind. Yes. That's why I agree with the PTA and DCB tactic. And in some bailout situations, we are stenting.
Exactly. This is what we are practicing definitely. We are using the stent. I will tell the patient several words. Нормално би било лекичко да ви боли, ако е много силно ще ми казвате. The patient is doing very well. He is excellent guy, very supportive. Very supportive. This is a 5 by 200?
Yes, 200.
This is a 5 by 200 balloon. Pacific,
with the
Pacific
exact one-to-one ratio, or pre-dilating sometimes? Or in this situation?
It's one-to-one. In this situation, it's one-to-one. We did a very tough case yesterday. You may believe or not, but a 4-millimeter balloon looked bigger than the necessary in a tiny lady, smoker for 50 years. So what we are mentioning is very important in case you want to avoid stenting. It's better to go slowly and a little conservatively, so not to put 6-millimeter balloon since the beginning, because the dissection is absolutely definition. It's not a probability. It's a definition. But in this case, it's the big guy. So 5-millimeter balloon is exactly one-to-one.
Okay. What do you do for the pain?
Yes. It's our general practice, since we are doing head-to-toe endovascular interventions, and many of them are not totally painless. We are practicing the so-called conscious sedation in most of the cases. So we put midazolam and fentanyl, conservative dose, in order to remove the pain, but to have contact with the patient if necessary. Okay, we inflated for 1.5 minutes the balloon, and we are going to observe now the result, and we'll decide together with you. We will decide what to do. Okay, we are going to proceed with an injection. Ще ви затопли кръка сега, Йордан. Не мърдайте. I think it's not bad. let's make one follow up, and let's prepare the DCB, because hopefully you will agree that the result is quite not bad.
Quite excellent.
And, yeah, and we can proceed with the DCB. Готова ли си? Ще проследим. We are going to take a look, of course, the distal runoff. It looks like it's probably not bad because it's extremely fast, the flow on the level of the previous occlusion. Die. Go, 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 go. Okay, excellent. Concentrate here. We are now to concentrate on the foot level, and we are make a small trick. We are going to make an aspiration from the sheet, from the tibial, posterotibial sheet, in order to create flow and not to. Okay. Субтракция. Йордане пак ще затопли. Inject. Давай. Not bad. Not bad. So I think we are proceeding to the last step, the drug coating balloon. In fact, treatment, local treatment on a conservative flow pressure. We are using 5 by
20.
5
The
by
same
200.
balloon, yes.
Yeah, 5 by 200. So the same size and the same length of the balloon like the treatment balloon. And now we are proceeding with the drug coated balloon.
Gore, leader.
Okay, let's go to the level of the stenosis. Up, up, up.
Okay.
Posterior is your first
A little
choice.
more. You mean by a balloon?
But no,
We
no,
have several.
posterior tibial is your first choice.
Ah,
or-
yeah. Very good. Professor Stankov will explain you a little more about this. Professor Stankov?
Yes. The primary choice always is the tibial, if it's not occluded. And we use anterior in the case when the posterior is occluded. But it's very comfort for me to the working from the posterior tibial artery, because the foot of the patient it's not in zone the part of the introducer.
In fact, it's also very comfortable for the patient to maintain the position, because it's very natural position of the leg during the puncture. Okay, this is the 6-7 atmospheres. I would prefer to go really nominally, not more than 8, in order not to cause late dissection, to avoid dissection during the preparation and to make dissection finally, and to spoil everything. So we are going to do balloon inflation for several minutes.
How many?
Едната камера, поне едната камера да е насочена към лицата.
How many minutes? It's your
For 2 minutes, I prefer long inflation in order to be sure that there is a full elution of the drug over the intima. And we are 1 minute and 12 seconds now. So waiting a little more. And
Too
we
long
are going
minutes.
to... Too long, really, absolutely right, yeah. For us like you, for us cardiologists, it's quite difficult to wait. You're right. We are not very prone to wait, but in this situation, it's better to wait in order to avoid dissection and any other complications.
And after that, we're most waiting for the inflation of the balloon.
Yeah.
It's not easy.
By the way, this is a very good remark. So the dilution of the contrast in the inflation device is absolutely crucial. And our practice is not to be a one-to-one ratio, saline to contrast, but to be 30% saline and 70% saline and 30% contrast. Because with nowadays machines, angiography machines, everything is much better visible and we don't need so much contrast in the inflation.
Okay.
That's very good
Absolutely
point.
great. And
According
absolutely,
to balloons and time.
absolutely.
Time of deflation.
And speaking about contrast, our approach is always without any relation to creatinine and glomerular filtration. After reaching 100 milliliters of contrast utilization, we put bicarbonate in saline as a protection of the contrast-induced nephropathy. Ще те затопли сега, не мърдай, държиш се прекрасно. I think it's not bad. I think it's not bad. The flow is fast, and we are going to make a final injection on the level of the foot with the same trick, creating flow through the sheath in the posterior tibial. We are going to remove the tubing, and we are going to be малко надолу. Така е супер. Айде още малко да се види началото на стъпалото. Още малко. Още. Още малко. Леко краниално. Така, супер. Окей. Final injection. Inject. Okay.
Very good result.
I think we are done. What do you think?
Just to measure the pressure of the tibial artery and the
it's
iliac artery.
Very good idea. We are going to measure the pressure through the posterior tibial sheath and the systemic pressure, and we are going to compare. Okay.
That's the usual practice for you, or now?
It's a more didactic, let's say, because it's a quite a good. We'll flush, and now after flushing, this is the pressure from the posterior tibial, but it's obvious that in fact the flow is very, very fast, and I don't expect a big difference. Difference from the.
And now in the iliac.
Yeah, and this is the iliac.
On the iliac.
Yeah,
in
convincing.
fact, it's probably
Very convincing result.
Yeah, probably 5 millimeters.
But we have
Dynamically convincing.
spasm of the tibial artery.
And of course, there is always some spasm, so it's unavoidable. It's you see it just on the tip of the sheet. There is a small spasm. That is, but in fact, 5 millimeters of mercury, even without spasm, it's absolutely acceptable. Okay.
Okay.
Any comments from your part?
I think it's very good result. The patient is claudicant. We must not be very aggressive in not to result in dissection and stenting at the end. So this is quite good result, I think.
I would like to show you both sides, five French access. So we have 5 French, probably with the camera, if possible to show here the arm, ръката на пациента да покажа.
Вмъкни кръвата. Не, издръпай пациента сам с масата. Да видим.
You probably see my finger over the 5 French sheet on the arm, and of course, the five French sheet on the tibial. So it's elegant five French vascular access. Okay, thank you very much for your
Very good.
attention.
Thank you.
Congratulations.
Thank you.
Thank you.
Thank you so much. Thank you, my team. Excellent job. Super. Thank you.
It was excellent case, and now we will rest a little bit. And wait for Professor Petrov.